Welcome. I'm Jay Bhattacharya. I'm a professor of medicine at Stanford University, and I'm interviewing Professor Sunetra Gupta from Oxford University and Professor Martin Kulldorff from Harvard University. And we're going to be talking today about the topic of herd immunity and its role in the right strategy to address the COVID epidemic. So Martin, from what we've heard, then it sounds like this novel coronavirus produces some level of immunity. And you're saying it sounds like good news to me. Like if it infects children at this endemic state, it's not going to cause that many deaths in the long run compared to if it hurt kids a lot.
Yeah, so in a sense, we're very lucky in that respect that this is a very mild disease for children. So in the long term, it's not going to do a lot of damage because of that. And in that sense, it's very different from measles, which is a terrible disease for children, which children die or go blind, for example. So we're fortunate in that sense, and we knew we were going to get a pandemic sooner or later. We get more of them, and some pandemic are hitting the older higher more and the younger more. So the fact that COVID-19 is a fairly mild disease for most children is a good thing.
So the idea of herd immunity then is not a scary idea where we've killed off the population. It sounds like it's a situation where the virus, in effect, just because of the way that all viruses work and the particular features of this virus, it's kind of under control. I mean, that's the end state, right, of this epidemic or pandemic?
It is the end state, and it's a question of how to get to that end state. So, for example, with measles, the only way to get to that end state in the absence of a vaccine is for a lot of people to die. But fortunately for us, the good news about COVID is that it doesn't kill young people. So we can, that creates the opportunity for us to reach that end state without a lot of deaths in the population, simply by, for a short period of time, 2, 3, 4 months, 6 months even, shielding those who are vulnerable. So this is not, again, I mean, just to stress again, this is not one of those childhood infections for which we rapidly made vaccines and which have helped so much in reducing child mortality, where the infection is really terrible in young people. So, which also raises the question of when and if we have a vaccine, whether that would be the right thing to do, to give the vaccine to young people. So, which brings us maybe to the next question, which you should be asking, not me, but how will a vaccine contribute to herd immunity?
Yeah, that's an excellent question. So we just talked about earlier that in measles, the vaccine sort of contributes to herd immunity by creating a set of people with whom if you interact, you're not going to get measles. Does the same logic apply in the coronavirus case, or the novel coronavirus case?
It does, but it's a question of how would they acquire that immunity? So in the case of measles, they are, at the moment, the way we have it, you get your MMR between the age of 12 and 15 months, and then it's boosted.
I don't remember getting it, but you know.
Well, of course we didn't. I got measles when I was 3 in Ethiopia. And then you have this cohort of vaccinated people who keep the virus at bay and prevent, as Martin so nicely explained, the infants who would be at risk, who can't get the vaccine because they have maternal antibodies, so that they are protected by virtue of a whole group of people being, well, at the moment it's a mix of them being vaccinated or, like us, having natural immunity to measles. So that's how it works. But for COVID, are we really going to go and vaccinate infants?
Yeah, that's a really good question. Do we one strategy is to you've mentioned the vulnerable, and from what I understand, Martin, you're saying that the vulnerable are the old. That's right.
Yeah, so we don't know what the nature of the vaccine that will be approved and in what ages will be have efficacy. For example, some vaccines works in younger people, but not so much in older people. So we don't know those things, and we don't know what the adverse reactions is. So it's sort of hard to say who should get and shouldn't get a vaccine at this point. But I mean, one thing is to vaccinate those who are vulnerable, the older and people with risk factors. Another one is to vaccinate those who spread the disease to generate herd immunity, for example, and that will be, I think, mostly working age adults in terms of COVID-19, where hospital workers or nursing home staff, like that. So they might not themselves be so much at risk, but they will then prevent from infecting those they work with who are at high risk. But we can't really say anything of that yet, because we don't know what the nature and the performance of the vaccine is, if and when we get one.
But I think it would be a fair guess to say that eventually, if we have a successful vaccine, herd immunity actually will be achieved through a combination of vaccinating the vulnerable or the adults who are able to act as a barrier, and still allowing young people to acquire it through natural immunity. So we're probably going to go for some sort of, my guess would be we'd go for a mixed strategy. So I think we should be thinking in those terms.
I mean, this is an absolutely fascinating discussion, but there's actually a really interesting point that in both of your answers that I think is worth exploring just a little bit more. Because you're talking about, when we first started talking about immunity and the spread of disease, we talked about it as if anyone could spread the disease to anyone. In fact, now you're talking about a population where a few people or some subset of people are more likely to spread it to others just by the nature of their work or their interaction. How does that change the picture about immunity? Because it sounds like it really does.
So that's the key factor, because some people have many contacts because of their profession. Maybe they are a cab driver or a bus driver, or they work in the supermarket. Other people do other kind of work. They're out in the forest all day, or a farmer. They might not have as many contacts. So in the generation of herd immunity, depending on who gets infected and who are immune, the percentage needed for herd immunity can vary a lot. So, for example, in the COVID-19 strategy, no respectable epidemiologist would claim that the level for herd immunity is X%. Nobody would say that, because it varies depending on who it is that gets immune. So, an older person living at home mostly, if that person gets immune, that doesn't really maybe going to help so much with herd immunity. On the other hand, somebody who's very active, student who is 25 and going to lots of parties and whatever, that person will contribute a lot to herd immunity. So therefore, in terms of finding out how many needs to be infected, it depends on who it is that get infected, how much we need for herd immunity. And it also depends on geography, because usually in a city, people tend to interact with many more people versus in the countryside. So typically, you need a higher level in a city to reach herd immunity versus in the countryside. But for COVID, it's impossible to know exactly what level is needed for herd immunity, and it's going to vary geographically. It depends on what strategy we use. If we protect the elderly and young adults are the ones who get natural infection, then it's a lower bar to reach herd immunity.
Right. So just to close the loop on that. So if we adopt a strategy where we protect the vulnerable, what message should we give to the young people about this? Should they be interacting with one another? Should they be? How should we think about that?
So I think we should let young people live their lives normally. Nobody should go out and deliberately get infected. Just like if you drive a car, we shouldn't deliberately get into an accident. But if a young person gets infected, they often are asymptomatic or mildly diseased, and they are at extremely low risk of death. So we cannot let young people live their lives normally, and they will then generate the herd immunity. And we do need to protect the older and other high-risk people, like Sunetra was saying, but the longer we push off the time when we reach herd immunity, the longer they're going to have to self-isolate, and the more difficult it is to protect them. Because, okay, sitting home for 3 months and not having any interaction, that might be possible, but to do it for a year or two, that is both very harmful, very difficult for them, but it's also reduces the ability to protect them, because at some point they're going to have to interact with somebody when they have a toothache and need to go to the doctor, the dentist, or etc. So the longer we wait for herd immunity, the harder it is to protect the elderly and other high-risk groups.
So on the other side of this debate, I've heard this idea that if we were to allow something like that, those kinds of interactions, then we would actually end up causing more deaths. So we'd end up causing fewer deaths in a strategy like this one, where we allow the young to interact and we protect the vulnerable, versus a strategy where we ask everyone to lock down. What's your view on that? I mean, obviously the goal should be to minimize deaths. What strategy would actually minimize deaths, even leaving aside the cost of the lockdown?
Well, lockdowns only delay the spread of infection. They can't completely prevent the spread of infection. So overall, you could say at best, even if you don't cap the cost of lockdown, it would be neutral, as it were. But there is another issue that we haven't talked about, which is that exposure to these seasonal coronaviruses evidence is now mounting that gives you some form of protection against infection, disease, and certainly death. So there is a real question to be asked about whether isolation itself wouldn't contribute to vulnerability. So we really need to think carefully about putting people in isolation.
Let me unpack that, because that's really important and a little bit unintuitive, I think. So if we have a lockdown, we have fewer non-COVID coronavirus infections that are mostly mild. Is that correct? Is that what you're saying? And if we because we have fewer of those, we getting some immunity to those other non-COVID infections would provide some immunity or some protection against the novel SARS-CoV-2 infections. That's what you're saying, right?
That seems to be the case, yeah.
So the lockdown actually could increase mortality, if that's true, from SARS-CoV-2, like a universal lockdown.
I think we need to worry. Yes, we need to be worried about that. Not to mention the other diseases like flu, where also some sort of re-exposure can top up your immunity. So we need to be really, cognizant of that setting in which we live our lives.
The other thing is, if we do nothing, then the group who are going to have the disease, then who generate herd immunity, will be some old and some young. If we do lockdown for everybody, then we'll push things in the future, but there will still be a certain proportion of old and a certain proportion of young who are get disease, about maybe the same proportion. On the other hand, if we do an age-targeted approach, where we help protect the elderly and other high-risk groups, while the young are allowed to live their lives more normally, then we're sort of shifting the proportion of who are the ones who are getting infected to herd immunity from being both old and young to being mostly young. And that will reduce mortality, because it's primarily the old who are at high risk of mortality. And we can't protect everybody completely, that's impossible. But the more we can shift in that direction, the better it is. But a general lockdown that sort of protects everybody doesn't do that. It just pushes things forward instead of shifting the risk from one age group to another age group.
Actually, can I circle back to one premise, Sunetra, in what you said? So in reading this literature about the cross-reactive immunity, it seems like it's now at this point well established that there are mechanisms, biological mechanisms, where that actually occurs. Now, but is what I've seen is some debate over whether it's protective or not protective. So what's your view on that?
That's precisely the question to ask. Is this, you can observe cross-reactivity, but is it actually functional? So at the moment, people are trying to drill down into that, and there are some studies that do suggest that if you look in a household, those people who haven't got the antibodies do have T-cell responses to other coronaviruses. So there are some studies that are starting to suggest that they are protective. But yes, indeed, I think that's still a question mark. But that's what we should be doing now. We should be focusing on answering these answering these big questions that still hover over some of the very critical components of this system.
Interesting. Okay, so but like let's say what's the worst case answer for the age targeted strategy for that question? Let's say the worst case answer would be that you don't have a lot of cross-reactive immunity, right? Is that accurate?
So what could be the worst case? Yes, there's very little cross-reactive immunity, and that by recommending that those who are not vulnerable, that they lead normal lives, that you get a huge spike in infections, and we somehow can't keep it from spilling over into the vulnerable population. So that would be
the worst case.
Absolute worst.
But that's a policy decision. That's not the biology of the virus. Because like what does it mean to protect the vulnerable? Like let's say in the United States or in the UK, what does it concretely mean to protect the vulnerable?
That is a very important question.
So first of all, whether we have cross immunity or not is of course very interesting to know, and it's very important in the sense it will influence how many people will get infected and also mortality. So in that sense, it's a very important question. But if it's what strategy we should use to minimize mortality, it matters much less, because whether we have that cross immunity or not, we should still pursue the age-targeted strategy. In that sense, it's sort of inconsequential in terms of deciding how to approach this pandemic. Now, how do we protect the elderly? We can never do it 100%, but we can do a lot of things. For example, in nursing homes, which is the most vulnerable population, we have to make sure that if the staff already have had it and immune, that's good. So the more of the staff that are already immune, the better. But if we can't only have immune staff, we have to do frequent testing of other staff. Also visitors who are visiting their parent or grandfather or grandmother or uncle or aunt in the nursing homes, they should be tested before, both to protect the person they visit as well as other nursing home residents. Also in terms of staff turnover, we want each resident to be exposed as few staff as possible, and staff should not work in more than one nursing home to minimize the spread. So there are certainly a lot of things we can do to protect the nursing homes, which we're doing better now than we did in the beginning. We can still do much better, but we are already doing better than we used to. The second group is older people in their 60s or who have risk factors who are in the working age population. We can do things there to, if they can work from home, they should work from home. A 30-year-old investment banker doesn't have to work from home. We don't need to protect that. He is at very low risk. But a 60-year-old teacher is good to let him or her work from home, not so much because there is from the students, but more from other teachers. So grading exams or grading homework, or maybe teach from remotely. So those older people who can work from home should work from home. And if they can't, then we could have some arrangement that they could take 3 to 6 months sabbatical. They could use, we can allow them to temporarily use Social Security or retirement funds to cover them during that sabbatical, so that they can stay away from the workforce because they are at high risk. We have also those who already retired. We can make sure they get help with delivery of groceries so they don't have to go to the supermarket where they could be exposed. If they see their friends they maybe should do it outdoors rather than indoors, if that's possible. The biggest challenge are the multi-generational households, and I have
Especially in poor countries, that's a big deal.
Yeah. Also in the United States, because in my family we had a situation, so we were able to rearrange the living arrangement to accommodate that. So maybe an older person living with their son or daughter should live with a sibling for a few months. Or during the we have had empty hotel rooms. Maybe they could be used temporarily for to house older people, to avoid multi-generational household for a few months, because you don't want to do this for too long. So if you drag out the pandemic for too long, then it becomes unbearable to stay away from your family for a year or two. But for 2 or 3 months, it might be more feasible.
How about in a place like India? How would you manage multi-generational homes? I mean, we were just talking about this before.
It is a very difficult issue. But I mean, one thing again, but this is again a question mark, we don't really know the extent to which living in a multi-generational home makes you more vulnerable. That is to say that there are some studies indicating that living in the proximity of young children actually bolsters your immunity, such that people in multi-generational homes may not be quite as vulnerable as the isolated 93-year-old woman living in a single-person council house.
Again, because
there was one study from Stockholm where they looked at the risk of people over 70 and over. And first they compared if you live with somebody who's a working age under 65, a working age adult under 65, versus living with somebody who's above 65 in retirement age. And they did find that there was a higher risk for those who live with working age adults compared to older adults. Then they compared, okay, if you live with a working age adult, what's the additional risk if there's also children in the household? And there were no additional risk from the children. So from that study, and that's only one study, so we have more of these studies. From that study, there's indication that yes, there is an increased risk if you live with working age adults if you're old, but there's no increased risk if you no further risk if you also live with children. And that's sort of in accordance with what you were saying.
There's a Scottish study in healthcare workers which shows actually that living with children reduces your risk of getting infected and being hospitalized.
Which is consistent with the cross-reactive immunity kind of idea.
Yeah,
because children are vectors of other
that's right,
respiratory viruses.
Mild vaccinations.
Yeah.
So there are all sorts of issues that need to be sorted out. But it is true, there's a huge challenge of how do you shield the vulnerable in certain settings, and but then if you at that point there's only one. I mean, you cannot get away from looking at the costs of lockdown.
Yeah.
So if you think India, and you're thinking of the costs of lockdown versus trying to shield the elderly, I mean, it has to come down to that.
Right. Okay. So the end point I think we've learned is not zero COVID. Right. Is that feasible according to both of you?
No.
Right. So that's not in the set. So what is in the set and what's on the table is this age-targeted strategy where you shield the vulnerable the best you can and let everybody else go, versus a strategy where you wait for a vaccine. And I've heard both of you sort of circle around that strategy as not really feasible in the long run setting, maybe even harmful for the long run setting. Is that accurate? How should we think about the debate between those two strategies? I think those are the two strategies people have in mind in the debate.
Well, first of all, I think there should be a debate at all, which there hasn't been. So it seems to me that waiting for a vaccine at the moment is not an option, just because of the high costs of these interventions that would suppress the virus. That's the main, the sort of very basic argument.
You mentioned earlier, yeah.
But then the other thing to consider is what the vaccine will do when it's available, how it would be incorporated anyway and no one's thinking about that. Everyone's saying, okay, there'll be a vaccine, and then we'll get herd immunity from the vaccine. And actually, we need to think a bit more carefully about what the vaccine will be able to do.
Right. So I'm hearing from both you and Martin the same thing, which is that we don't know that a vaccine would produce herd immunity very rapidly.
I think a better way to use the vaccine, and I really hope there will be a vaccine soon, would be to protect the vulnerable.
Yeah.
So that would really kind of seal that strategy,
right,
of protecting the vulnerable and allowing herd immunity to build up through natural infection in those who are not vulnerable.
But we can do that now without the vaccine.
We can start on that process.
Yeah.
Yeah. So whether we are going to reach herd immunity, whether we reach it with the vaccine or through natural infection, the focus right now should be the same: to protect the elderly and other high-risk groups. So whether we have a vaccine 3 months from now, a year from now, 5 years from now, or never, our current focus should be to protect those that are vulnerable, the elderly and the other high-risk groups. So in that sense, the strategy for them is the same. And then the question is, for children, should they go to school? Well, they're not at risk much for COVID. And if they're out of school for 2 weeks or a month, that's not going to make major damage. But we're not talking about more than half a year. And the collateral damage is enormous. And it's not just their education, it's their physical health and mental health. And there's other collateral damage. So whether we have a vaccine very soon or never, I think that the correct strategy is to do the absolutely best we can, and much better than we do now, to protect the elderly and high-risk groups while we let younger people live their lives. And then we'll see who gets first. Does the natural immunity comes first? The immunity from natural infection comes first, or does the vaccine comes first, or a combination of the two? And that's sort of almost impossible to say, because we don't know what level is needed for herd immunity. We don't know what immunity level we have right now. The antibody test will tell us like a lower bound of what it is, but there's immunity beyond that, but we don't know how much beyond that. So we don't know kind of how close we are to herd immunity, and if some places already may have it. And we don't know when the vaccine is coming, if it's coming. So I think the strategy is the same, that we have to protect the elderly while young children and young people need to be let to live their lives normally, because otherwise there are enormous collateral damage.
So, I mean, I completely hear you, and I think it sounds like you two are in complete agreement about that point. So let me make one other argument from the other side. The argument sometimes I hear is that if you let young people live their lives, they will pose a risk to the elderly, to the vulnerable. Now, I've heard the argument you're making about the development of population immunity. Is there any force to that counter argument at all? Is that like my son or daughter gets infected, they interact with my mom, who's 80, they pass the disease to her. Right? That's I think the intuitive force of the counter argument. How would you answer that?
Well, I mean, that is of course the reason why we've been thinking about this problem at all, now that we know that the risks to children under 20 extreme, I mean, people under 20, it is so low. And so it seems that if the choice is between your children not seeing your mother for 3 months, or, taking a test and then going through all the hygiene procedures and social distancing and seeing her from a distance or maybe outside, all of that seems to be easier to achieve or cause less harm than your children not going to school or totally self-isolating
Right.
in order to be able to visit your mother.
So this is it's a comparison of risks and costs on both sides of this policy. It's not simply we're exposing exposing everybody to the virus and acting irresponsibly, right? Is that a right characterization?
Yeah. So it's more important for children to go to schools than to be able to visit their grandmother. On the other hand, you can still visit your grandmother because you can do a test. So it doesn't have to be one or the other. So yeah, if the child is sick, they shouldn't go and visit their older relatives. If they are asymptomatic, maybe still you want to be safe and make sure they take a test. And if they are positive, you can wait with the visit maybe for 2 or 3 weeks. So to me, that's much a lesser inconvenience than to pull children out of schools. And especially for working class children, that's a major problem, because among those of us who are more privileged, we can do tutors or private schools or pod schools, etc. But that's not available for everybody. So this is hurting the working class children the very most.
All right. Well, Sunetra, I'll give you the last word.
I had that last word. Oh yes. So, and at the end of the day, I think it's also very important to contextualize this against the risks that we do live with, other infectious disease risks that we are happy to live with when it comes to visiting our grandparents. So many elderly people do die of influenza, for example, and the caution that we exercise in terms of exposing them to COVID has to be viewed in the context of the fact that we do expose our grandparents regularly to influenza. And it's only when the risk of COVID is exceptionally high that we really ought to be adopting those precautions, because once again, they too have a cost, because grandmothers want hugs.
I know. Thank you very much, both of you, for this enlightening discussion.
Thank you, Jay.